So maybe I could take a bit of a pause there and take questions. Yes?
I had a nephrectomy.
Yes?
In 2003.
Yeah? Yeah?
That
No. Providing the function of your other kidney is suitable, and we have transplanted patients with a single kidney before. Often there is some growth and of natural growth of the other kidney to accommodate function in some cases, but although we obviously have to look at carefully on an individual basis, it wouldn't automatically mean that you couldn't be considered.
Okay, thank you.
Is that a relief?
I believe that the disease actually goes up into your piece.
Yes.
Because that's your PFT, isn't it, from your airways? Is it not? Is that not? That's where your PFT comes from.
Oh, your lung function, yeah, the air, yeah.
So if you have a transplant, do you not get new airway as well?
Yes, the transplant. When you transplant the lung, it's not just a sponge of the lung that you can transplant around the airways, and the main airway is joined on to, that the windpipe comes down and splits into a left and right. So where the join is usually just where the windpipe is split into the main airways to the right and left lung. That's where the join is. So it's true that most of the air that is that you're measuring in lung function after the transplant reflects air coming from the transplanted lung. It's new air. Yes. Yeah.
This one's a bit simplistic.
Oh, probably not. They're usually the most difficult questions to answer.
Well, obviously because you've got to accommodate the heart on that side, the left lung is differently shaped inside
Yes.
from the right.
Correct.
So if you're doing just one lung transplant, does it matter?
No.
If all you've got is the left and put it into the right?
No. What we know, you'd have to put the left lung into the left and the right into the right because of the shape. That's absolutely true. So you can't flip and flop as that, because that would cause some compression because of the shape of how things are. Yeah. Interestingly, some patients, are born with hearts on the wrong side. You've seen that, and you have to accommodate that. So it's not really relevant to this group, or very common. But in some cases of patients with bronchiectasis, another lung condition, where there is an association, you then have to be quite careful in remembering which one to put in. And surgeons are pretty simple folk. We have to write little notes and remember. Okay, well that was quite a little pause, but I hope that was helpful. It was, yeah, indeed. But the bottom line is, as I was saying, if you look now at the progression for LAM patients, and I've abstracted the sort of survival, I think, as a group, median survival from the French series and the European series is now in excess of 10 years, which is encouraging for all of you. But it's not just, of course, surviving, it's how you survive that's most important. So here I've taken, and these aren't just LAM patients, these are functional status of cohorts of patients who are reported to the ISHLT. So if we look at the survivors who've survived 10 years, the red bar, over 80%, no activity limitations. So even though there are problems following lung transplantation, if you survive 10 years, by and large, the quality of life that you have at 10 years is good. And in terms of average activity, no activity. Now, not all of these people will be able to compete in the London Marathon, but in terms of, if you just think about of 10 years previously, the level of function dependent on oxygen and really very limited, I think it is a success story. Now, trying to get evidence, as you've already heard, is a problem. This isn't ideal evidence, but there was some data on the NHLI, the American LAM registry, and they looked at cohorts, and that was a cohort of transplanted patients versus a group that was still regarded as too good, and they looked at the general health of those patients. Now, of course, this is a bit awkward because you've got to be, as I've already said, good enough for a lung transplant in terms of your overall health status, but but bad enough from a lung viewpoint. But the bottom line is there was better health reported from the transplant group in terms compared to the group of patients who had LAM but was still too good for a transplant, although because of the immunosuppression they had lower blood counts and worse kidney function. And patients had the same oxygenation, similar lung function, though the transplanted patients had less airflow obstruction. And as I said before, in the early days of transplantation we were pleased to get patients through 1 year. We're now looking to getting increasing and pushing survival out to 20 years, and we're addressing the issues of chronic graft dysfunction, quality of life, preserving kidney function, and the non-invasive diagnosis of rejection, because we'll come on to that, how we do it at the moment. Now, one of the questions we always get asked, and I'm sure you're all familiar, is can LAM come back in my new lungs? And the answer is yes, but the experience to date suggests it's pretty rare. Of course, diagnosing it post-transplant can be quite difficult, but if you take biopsy data, and we do regular lung biopsies after transplantation, around about 6% of patients will have evidence of LAM cells back in their lung. But the good news is that to have it associated with any loss of function is pretty rare. In fact, is much rarer, down to around 3%. Interestingly, and we can all learn from each other, there are aspects of patients following patients after lung transplantation for LAM that perhaps give us some useful information about LAM itself in its initial in its status unrelated to transplantation. There was a feeling once that there had to be myelipomas to get recurrent disease, but now there are cases reported without screening for these tumours. You can still see evidence of LAM cells back in the lung. But there are now numerous reports suggesting that if it does happen, and there is loss of function, those rare occurrences, that rapamycin can be helpful in that situation, and we'll come on to that in due course. Now, I made the point earlier that if you're doing a lung transplant, all you're actually treating in a disease that has other manifestations is the major aspect of that problem, the lungs. So can other LAM features still cause problems? Well, the answer is yes. In single lung transplants, there's something like a 6% pneumothorax rate on the other side reported. Chylothorax can occur, and angiomyolipoma present before can enlarge, get other mass lesions relating to LAM, and bleeding can occur. But again, the good side is there are increasing reports where particularly chylothorax and increasing mass lesions do respond to the introduction of rapamycin. Now, there aren't controlled trials in that, but there are plenty of reports of controlling, if you like, those problems. So we're aware that it's not just the lung that bears the brunt of this condition, and we can adapt, if you like, our treatments to try and treat those issues. Now, if you have a lung transplant, is it, do you just bye-bye Newcastle, that's it, thanks very much, see you sometime at a nice LAM meeting? Sadly not. Really, there's a welding of liaison between the transplant centre, and you'll require very close follow-up during the first year. It's something like every 2 weeks for a couple of months. Most patients are going out of hospital. Most people are going home at a distance from the trust, from the hospital, at around about a month, some sooner, some later. And then there's fortnightly follow-up, monthly follow-up, and 3-monthly follow-up. Regular lung function, bloods for life pretty well every 6 weeks, and lots of bronchoscopies, as many of our patients know. And of course, we're doing quite a lot of research, so you're inundated with requests to sign consent forms for various studies.